Hi, good morning, everyone. Welcome to our yet another episode of CMAAO International Weekly Meeting. Today, we are featuring a very important discussion, the diabetes, the obesity. I think we all have questions. So we have an expert today, the diabetes, obesity in Asia and Oceania, endocrine challenges and solutions. If anybody wants to enter this session, you can come in at Zoom at 818-8591-1572 and ask the questions at the end. Dr. Saptarshi Bhattacharya is an MBBS, MD, General Medicine, and DM in Endocrinology. He's a senior consultant in endocrinology at Indraprasth Apollo Hospital, Delhi. He's highly regarded specialist with expertise in managing diabetes, thyroid disorder, PCOC, PCOS, obesity, and various endocrinology imbalances. Dr. Bhattacharya is well known for his patient-centric, evidence-based approach. Sir, I welcome you on the board and enlightening us for the session. Thank you so much.
Thank you, Saurav, for the introduction, and a very good morning to all of you who have joined. It's a pleasure to connect with all of you on this very important topic. And without much delay, so we will be discussing diabetes, obesity, syndemic, especially in Asia, Oceania context, and there will be some aspects which will be different, but there will be others which are very much similar. And so one challenge is that, as we are discussing right now, that the bulk of the population is in Asia and Asia Pacific region. So almost, even though it might occupy only 1/6 of the world map geography wise, but 60-70% of the population are actually here. And if you look into diabetes numbers, in this population, they account for more than 50% of the diabetes in the world. So we are facing a huge challenge of diabetes, and as we are getting to understand more and more about it, we know that it's a majority of the type 2 diabetes which is occurring in India or Asia or in this part of the world is being driven by obesity. So obesity might sometimes be visible. So it can come up in a BMI scale, and we might actually understand that, okay, this person is classifying is in falling into the criteria of obesity class 1 or class 2 or class 3. But there will be other situations, especially in Asian context, where the person might be apparently having a normal BMI, but may have lots of hidden fat, or what we call abdominal obesity or visceral fat, might not show up in the BMI, but actually still this visceral fat, which is the primary driver of metabolic complications and cardiovascular disease, can cause a lot of complications, including diabetes, cardiovascular disease, kidney disease, hypertension, dyslipidemia. So this is a unique challenge which is partly apparent. The numbers are not looking good, so it's going up more and more. But again, we do understand it's being driven by obesity, but a major part of the obesity in Asian context, that is actually a hidden obesity, and we might not actually recognize it on the face value. So this is the obesity prevalence globally. So if you look into this part, of like Asia, China, and rest of South Asia, and even in the Middle East, so the numbers are, so it's comparatively in the greener area. So if you look into the BMI category, so if WHO will be doing an assessment, they will be doing it according to BMI. But we understand that BMI, as we are discussing, it has some limitations, because it will not measure abdominal obesity or visceral obesity, which is the primary driver of all these complications. And what we know also, that the obesity rates are rising world over, both in men and in women. And if you look into Southeast Asia numbers, so overall the all the BMI more in the obesity category above 25, it's like going to be 35% of the population among men and around 44% among women. They're going to be in the obese category by 2030. Already we are like 20% and 39%. These are numbers from Southeast Asia region in 2010, 2015, and 2030. So we see the numbers are actually both the percentage, and since the population density is very, very high, also the absolute numbers both are going up tremendously, and that is something which is going to cause a huge amount of not only medical burden is going to go up, but also the overall burden to the economy, the society, the country, everything is going to go up. So even if you look into the Western Pacific region, so it's projected to go up to 51% and among men and 37% among women. And our BMI categories, as we are discussing, so we are predisposed to complications at a lower BMI. So our BMI threshold is different. So uh, in Asia, the obesity is classified in a different way. So 23 to 25 BMI is overweight, and more than 25 is actually obesity. And that has a very, very sound logic, because what we see in Asian context is that if a Caucasian develops a certain set of cardiovascular complication at a particular BMI, say at a BMI of 30, the Asians will have similar complication rates even at a BMI of 25. And again, the answer remains in the excess adiposity, excess visceral fat. And so what we are trying to reinforce again and again, that our adipose tissue, and even though it might not be that much of subcutaneous adipose tissue, so that it actually makes us look uh, having excess weight, but since the visceral adipose tissue is very high, we are facing a lot of complications. So diabetes around the world, so we are talking about obesity, now we are shifting to diabetes. So this is the overall diabetes prevalence in as per the International Diabetes Federation figures. So if you look into the current numbers, it's like 588 million, and it's supposed to increase. So this is the continent wise breakup. So Southeast Asia, it's like 106 million. You can see that almost one fourth of the diabetes is in Southeast Asia. Another 215 million is in West, Western Pacific. So together, this is almost more than 50% of the diabetes burden of the world. So you can see the challenges we are facing. So even though the geographically we are limited, but overall it's a huge, huge challenge, both in numbers of density, both in numbers of prevalence. So and this is also showing up in, say, gestational diabetes. So 1 in 5 live births are actually being affected by gestational diabetes mellitus. If we look into like 1 in 8 adults have impaired glucose tolerance test. Even we know that pre-diabetes we is a condition which is like an intermediate state, but it might not be that benign a condition, because also we tend to have cardiovascular as well as some microvascular complication even at the stage of pre-diabetes. So these are numbers which are alarming, and we really, really need to not only have individual pathways to move ahead, to bend the curve, but also we need a larger approach from the society, from the country, from the overall approach to lifestyle should change. And these are diabetes in Southeast Asia numbers. So these are just more of the details which we are discussing. But again, so very, very alarming. And it's actually estimated to go up by almost 73%, to double up to almost 190 million in 2050. So the numbers are already high, and they're projected to go up even higher in the coming years. Similarly, the numbers are like 215 million in Western Pacific, but again, it's projected to go up to almost 253 million, and so huge numbers we are facing. So if we look into this particular area, so we are talking about Asia and Oceania. So there are three distinct phenotypes actually we see. So if you look into South Asia, we have the thin fat phenotype. If you look into Indians or South Asians specifically, so they are not apparently obese, but they have high visceral adiposity and insulin resistance. So that is classically called the thin fat phenotype, and metabolic dysregulation can occur even at a low BMI. So that is why the Asian BMI thresholds have been changed. Now, if we look into East Asia, so their defect is slightly different. So we tend to have more of beta cell dysfunction, secretory failure. So not just so much of insulin resistance. So that is something which is slightly different. So, and if we look into, say, Australia or Oceania, so we have the typical Caucasian phenotype. So where there will be excess of adiposity, both subcutaneous as well as visceral, more maybe of subcutaneous. And even though with a high BMI, they might be doing quite well because the muscular the contribution of lean mass or muscles to the BMI will be quite high, and they will be hyper adipose. So their primary defect will be insulin resistance. So there it's a variable group of population if you look into Asia and Oceania combined together. So, and depending on the phenotype, we might have to change the treatment strategy also. So if somebody is from, say, is having is from the Caucasian phenotype, so that they will be requiring more of medications which can address the insulin resistance. So things like earlier we were focusing on metformin, and now we have the newer GLP-1s which actually have a remarkable effect in reducing weight and adiposity in South Asia. So even though what we need to understand is we will require so still primarily because of the visceral adiposity, insulin resistance plays a major role. So conditions, so medications which can bring down the adiposity, even if the BMI is not so high, they might be eligible for these medications and they actually might get benefited. And there are actually studies that DPP-4 inhibitors do quite well in terms of HbA1c reduction in South Asian context. So that is something which we can change according to the phenotype. And East Asian, so if their primary defect is beta cell dysfunction, they might be requiring early insulin and they initially might respond to sulfonylurea. So these are broad classifications. Ultimately, you need to work on the individual. So, but as a group, if you are discussing the overall demographics and the pathophysiology of the region, so this is how we can differentiate. So South Asians, the typical thin fat phenotype, early beta cell exhaustion, high prevalence of MASLD, and they develop type 2 diabetes at a lower BMI than Caucasians. East Asian, the typical trajectory is that of early beta cell failure. Sometimes the incretin effect is also lost, and the incretin-based therapy also work quite well. They also have a lower obesity threshold, and so that is why we have, as we have been discussing, that we have a lower obesity cutoff. On the other hand, so if the Caucasian population will have more of insulin resistance, there will be excess of both subcutaneous fat as well as partly visceral fat, and they might actually benefit the most from losing weight. And we were discussing again and again, we need to recalibrate the BMI scale and according to the uh, presence of adiposity in a particular population, and we have different cutoffs for BMI in Asian context. With this, I think we had a brief discussion about the epidemiology. Then we also learned how the pathophysiology in the Asian and Oceania context might actually differ. And we now move on to some basics of type 2 diabetes management. So we have moved from a glucocentric approach to to an approach where it's more person-centric, individualized, and the ultimate focus should be to prevent complications. Cardiovascular complications will be the primary driver of mortality, accounting for almost 60 to 70% of mortality in diabetes. And the rest will be 20, and 20% will be like renal causes, and the rest will be all other causes combined. So we need to, if we are trying to overall improve diabetes outcome, so we need to not only reach numbers, but we need to reach numbers in a way where we can simultaneously bring down complications like cardiovascular disease and renal disease, and also something like MASLD also has come up in a major way, so which is also going to be a major contributor to mortality and morbidity in diabetes. So obviously, if we are trying to address, we need to have a holistic goal. Lifestyle management will remain in an integral part of treating diabetes and obesity, in spite of whatever medications we new medications we have. So the physical activity, diet management, smoking cessation, restricting alcohol, so all these actually should remain the pillar of management of both diabetes and obesity. We also need to be we have very newer and newer emerging molecules which have a very strong promise of bringing down obesity and hyperglycemia. But again, lipid management, blood pressure management, they remain equally important, and we are having medications which can actually protect our organs. So we have the SGLT2 inhibitor, GLP-1 receptor agonist, RAS blockade has been there for a long time. So these are molecules which can actually prevent complications. And so irrespective of our glycemic goal, we should, whenever there are risk factors or whenever there is a past ASCVD or renal disease, we should optimize the use of these agents irrespective of the glycemic status. We'll briefly discuss the medical nutrition therapy. So it has to be a balanced diet, whatever part of the world you might stay. But Asians have a problem that their diet is rich in carbohydrate. The Caucasian diet might be more rich in protein. Fat content is also, like, a lot of saturated fat is still there in Asian diet, especially in Indian diet. And it's very, very important that trans fat should be totally zero. That is a WHO recommendation. So all guidelines recommend that. So it's important to read the labels and make sure that the trans fat is totally zero. This is the guideline from Indian Endocrine Society of India. I'm sure we have similar guidelines from other parts of the world. So MNT is an integral part of diabetes and obesity management, and it has to be a patient-centric advice. So there are different types of diet. There are when diets, there are what diets, but again, ultimately, is the calorie restriction which matters. Ultimately, is the balance between protein, carbohydrate, and fat intake. And again, if you are having carbohydrate, you need to be sure you are not having simple carbohydrates but complex carbohydrates. Also, if you are having fats, you need to be sure that you are taking the right fat and not taking excess of saturated fat. And trans fat should be totally zero, and the diet should be primarily based on fat which is rich in PUFA and MUFA. Lifestyle changes, even though it might not translate directly to weight loss, so but in spite of that, there are multiple benefits of lifestyle changes. So this is the exercise recommendation which is like followed by recommended by most societies. So at least 150 minutes of moderate intensity aerobic activity per week, 2 sessions per week of resistance exercise on non-consecutive days, and also it's important to incorporate flexibility and balance training. So diet, exercise, it remains important. And even if the weight is not coming down with exercise, there are actually multiple benefits. So with even with the best of medication, I will reinforce that lifestyle should remain the cornerstone of therapy for diabetes and obesity management. So both think adiposity, insulin sensitivity, arterial compliance, endothelial function, lipoprotein particle size, cardiorespiratory fitness. So in spite of no visible effect on BMI, because weight loss is not going to cause a lot, exercise is not going to cause a lot of weight loss unless you are also restricting calories at the same time. So that is what most meta-analyses and RCTs have shown. But in spite of that, even if somebody is not losing weight, there are multiple benefits and should not be ignored and remain a very important component. So The diabetes management has changed, so we kept on having these algorithms. This is the ADA 2026 standard of care. So we need to have a comprehensive goal of care. So we start from person-centered characteristics, then consider specific factors that impact choice of treatment, use shared decision making to co-create a management plan. So you might be on one page, and the care seeker might be on the other page. So it doesn't usually work. You might feel, okay, for this particular man, insulin is the best treatment. He feels that, okay, I can move on to GLP-1 and lose my weight. And so again, we need to discuss, we need to reach a common goal and implement a plan which is smart, which is specific, measurable, achievable, realistic, and time limited. Implement the management plan and provide ongoing support. And if whether the person is improving or not, we need to review and agree on the management plan. And if it's not working, again we need to reassess and start the whole cycle once again. So the A1C goals have kept on changing. So we all know that if somebody is young, so we need to be need to be more aggressive, because they have more years ahead to come up with complications. So if somebody is early into diabetes, comparatively young, so we should go for early intensive glycemic control. If somebody is elderly, multiple comorbidities, very higher risk of hypoglycemia, so we need to maybe bring down the HbA1c target to 7.5 or 8%. So this is something which you need to keep in mind. So HbA1c goal. So HbA1c still remains important, because HbA1c can actually translate to lowering HbA1c. Can actually, we have seen from UKPDS, which was a study which was published, which was done like 2-3 decades ago, and even EASD last year, this was presented that even after 40 years of the UKPDS study, 44 years of UKPDS study, the people who had gone into the early intensive glycemic control arm, still their microvascular and macrovascular benefits persisted. And even though the trial has been discontinued for almost 35 years, but people who went into early intensive glycemic control arm, and at that time we didn't have agents like GLP-1 or SGLT2 inhibitors. So they were doing this trial with sulfonylureas like chlorpropamide and glibenclamide and metformin and insulin like NPH and regular insulin. So in spite of those agents, if we reached reached that state of early intensive glycemic control, there are actually long-term sustained benefits. So glycemic control still remains important. On the other hand, we had the trials like ACCORD and ADVANCE, which some of them actually showed, like ACCORD uh, showed increased mortality with in early intensive glycemic control. So, but again, those were trials which were where the patients were having advanced diabetes, having more of complications. So if you are at that stage where the complications are already there, so maybe intensive glycemic control might not be the best strategy. But early diabetes, no complication, no risk of hypoglycemia, the lower you can get, the better it is. And we have agents like SGLT2 inhibitors, GLP-1 analogs. We also have agents like metformin and DPP-4 inhibitors also. So we have almost 3, 4, 5 molecules which do not cause a group of molecules which do not cause hypoglycemia. So you can actually, so the major burden always for achieving glycemic control has been always hypoglycemia and weight gain. So, but we can actually do it by newer agents without causing hypoglycemia, without causing weight gain. So the lower the HbA1c, the risk is linear, and we have seen that people who have, say, overweight or obesity and having pre-diabetes, and they're getting GLP-1 analogs, and they're going into normal glycemic range, and definitely that will have a long-term benefit in terms of severe risk reduction and reduction in other complications. So we have so for a very long time, if we look again, go ahead again into the ADA 2026 standard of care. So for a very long time, metformin had been the cornerstone of therapy as the first line agent, but the recent guidelines say, so irrespective of glycemic status, irrespective of whether you are using metformin or not, if somebody has cardiovascular and kidney risk problems, you need to use agents like GLP-1 or SGLT2 inhibitors, especially in the setting of ACVD or high CVD risk factors, which can bring down bring down the CV risk and cause and have proven CVD benefit in our cities. So same for heart failure at having heart failure, at risk for heart failure, SGLT2 inhibitor, irrespective of the glycemic status. So these agents actually have shown benefit even in the absence of diabetes. So should be incorporated in part of the therapy if there is a risk for heart failure. Chronic kidney disease, SGLT2 inhibitors should be again along with AC inhibitors or ARB, and maybe we can also think of the newer non-steroidal melanocorticoid receptor antagonists like finerenone. So these are agents which can decrease this CKD progression. They can bring down albumin excretion, bring down the creatinine levels, and improve the EGFR. So these are agents which should be there in the management pathway irrespective of glycemic status. So if we are talking about management, be it in Asia, be it in Oceania, be it in Australia, we need to have agents where we can give our patients the benefit of the or the advantages of the CV protection and kidney protection these newer agents offer. Metformin still remains an integral part of therapy, but as we have discussed that it should not, whether you are using metformin or not, if somebody has risk factors, so that has to be optimized. In many of our contexts, including in Asia and in Pacific region where beta cell dysfunction is common. So maybe sulfonylurea still have a role. DPP4 inhibitors, so they have the advantage of being a very, the HbA1c reduction is modest, like 0.6 or 0.7%, but they are one of the most well-tolerated therapy. They are more or less CV neutral, apart from saxaglitazone, which had shown some increased risk of hospitalization due to heart failure. So other than that, they have their primary advantage, very well tolerated, minimal side effects. So that is something which is important, because people do struggle with adverse effects sometimes. So sorry, this is an agent which can actually bring down the severe risk, bring down the hyperglycemia, but does not offer benefits like we see with an SGLT2 inhibitor. So we have multiple trials of SGLT2 inhibitor where with empagliflozin, dapagliflozin, canagliflozin. So even sorry, EMPERIC was a trial where the major reduction in CV risk reduction along with the reduction in CV death and all-cause mortality. So one of the first trial which after very long time actually a glycemic glucose lowering agent showing CV benefit. So empagliflozin was one of the standout molecules at that time. After that, we have obviously so GLP-1 analogs which have shown CV benefit. We have other SGLT2 inhibitors also which have shown CV benefit, but EMPERIC was a landmark trial, and because there were so many parameters which actually improved, and now we have also the GLP-1 analogs which not only will they have maybe become more popular for their weight lowering potential, but they also, we need to understand. So if somebody has an ASCVD, if you are using a GLP-1 analog like liraglutide or dulaglutide or semaglutide, which has proven CV benefit, it's not CV safety, they have CV benefit. They bring down the 3-point MACE in RCTs. So this should be part of the treatment irrespective of the glycemic status. Even we have in obesity also, we have a dedicated CV outcome trial with semaglutide irrespective. So these were people who didn't have diabetes. In spite of that, they had ASCVD, they had obesity, and semaglutide was given. Compared to a placebo, there was actually CV protection. So these are molecules which are remarkable. And since we are discussing that the visceral adiposity is the primary driver of cardiometabolic risk, so we need to integrate our diabetes management with weight management. So we have molecules like GLP-1 analogs, and they are going to come up in a major way, and we need to treat obesity along with diabetes. So if you look into the ADA guidelines, so management of obesity actually has taken up a significant share of the guidelines. So because these are conditions which are very, very closely interrelated. Diabetes is a complication of obesity or visceral adiposity. So whenever we are treating diabetes, we have to keep in mind the obesity or the weight gain aspect as well. But obesity itself has multiple complications. So you look into mental, mechanical, metabolic, and financial burden or monetary burden, the four M's. So we need to treat obesity, recognize it as a chronic disease, because there are multiple complications. So we don't think about treating diabetes. We know that the benefits are proven. We don't think about hypertension, treating hypertension or treating dyslipidemia, but we still sometimes think about treating obesity. But we need to understand that obesity treatment is also, obesity is a chronic disease, it's a relapsing disease. So we need to integrate obesity management not only with diabetes but also in people who are having obese. So even though they don't have uh, obese diabetes today or severe complications today, they are at very, very high risk, and we need to overcome these barriers. So there are multiple barriers, like the patients are unaware, so we also are sometimes reluctant to start treatment. There are obesity bias, there are fears of adverse effect, the cost still remains a challenge in major part. So lack of efficacy used to be a major constraint maybe 5 6 years back, but we have the newer agents which actually have changed that. So we have very, very efficacious molecules which can bring down the weight, and adherence and compliance remains a major challenge. So these were the earlier molecules which were FDA approved. We have tirzepatide also on top of that, and we also have oral semaglutide coming up at a 25 mg dose, which has been approved by FDA. But if you look into the first four, their efficacy was actually like say 5% to 8%. So not really working. When things actually changed with the advent of semaglutide and tirzepatide. So these are molecules which actually bring down weight by 15 20, or we have agents like triple agonist called retatrutide, which brings down the weight by 25%, almost something what a metabolic surgery or a bariatric surgery offers. So this is a whole group of molecules which are collectively called nutrient stimulated hormone based therapy. So many of them will be incretins, the others will be non-incretins, but they combination of gastrin, glucagon, GLP-1, GIP, CCK, zenin, all being actively researched, very, very strong weight loss. We know, and we have been using semaglutide. So these are the step trials. The weight loss is in the range of 15 to 18%, as you can see in the several step trials for weight management. Even in diabetes management, maybe the weight loss is slightly less as compared to weight management. The weight comes down by almost 18.2% with even after 68 weeks of therapy. So and also there are effects beyond weight loss. Obviously, we know that the glucose metabolism is going to get benefited, the CV risk factors, the dyslipidemia goes down, the markers of inflammation like C-reactive protein, that goes down, and you get multiple benefits related to weight-related outcome, be it obstructive sleep apnea. In younger females, we see remarkable improvement in PCOS and fertility. We also see improvement in say urinary incontinence. We have trials to suggest that semaglutide has a benefit in terms of reversing fibrosis in MASLD or MASH. So only two molecules are actually approved by FDA for improving fibrosis. One is resmetirom, one is semaglutide. So that is something which we need to incorporate in our practice. And we were talking about visceral adiposity, abdominal obesity. So it has an effect on waist circumference. So this has been the topic of debate, that whether it's only the fat we are gaining and how much muscle mass we are gaining. So if you look into the ratio of the of adipose tissue loss versus lean mass loss, it's roughly 30% or 25% lean mass loss will be there, but that will occur with uh, any program, which may be a dietary program or bariatric surgery or other medicines. So there will be some amount of lean muscle mass. The ratio gets preserved or better, the lean mass and adipose tissue ratio. And also at the same time, you need to ensure and encourage that the person should be taking adequate amount of protein, and also encourage these people to do strength training so that the lean muscle loss is minimum. So the visceral fat area, that also goes down. There is significant improvement in metabolic risk factors. So GI side effects will be are the primary challenge for this group of therapy. All or can occur in like 30 to 40%. Usually settles down as we keep on treating them. The side effects tend to settle down. That is why we start at a lower dose and gradually build up the dose for these molecules. But again, there will be like the discontinuation rates approximately vary from 5 to 10% in our cities. So maybe 1 in 10 or 1 in 20 will actually not be able to continue it because of GI side effects. So then we have this newer molecule tirzepatide, which is not so new anymore. So we have dedicated trials also where we see weight loss in the range of 20%, and we have it works in diabetes as well as in obesity, the 19 to 20% weight loss. So one area where we people do ask whenever we offer this treatment, that what will be the rebound if we discontinue the medication. So this is the Surmount 4 trial where they specifically looked into it, and they found that if you offer this molecule and reach the maximum tolerated dose, the weight goes down by almost 20% in 36 weeks. Then what they did, they continued this molecule in for another 52 weeks in one arm. In the other arm, they discontinued the molecule and gave a placebo. So the placebo arm gained back almost 10% of weight. So if somebody is starting at 100 kg of weight, so at the end of 36 weeks, he or she is likely to come down to almost 80 kgs. And if you stop the molecule, most probably they will go up to 90 kgs, but still there will be a deficit of 10 kg at the end of say 1.5 years or more. But again, if they continue to keep on taking tirzepatide, the weight actually goes down to almost 75 kg. So these are remarkable figures. We never had this type of benefit, and there are a whole lot of molecule. And if you look into retatrutide, and there are other triple agonists also coming up. So the weight loss average, this is average weight loss. So this is the mean weight loss in the trial. So that is like 25% weight loss, never seen earlier with in any other molecule. So again, moving back to basics of management. So we if we look into diabetes, so we need to ensure the A, B, C, D, E, and also we add O somewhere where weight they have weight also. The obesity component remains very, very important. So we need to assess the CV risk, think of aspirin, control blood pressure, control cholesterol, lifestyle changes, including cigarettes, diet and weight and obesity. It's very, very important. Glycemic control and exercise. But all individuals are different, all countries are different. So we need to keep in mind our available resources, the what our phenotypes, our genotypes, our social patterns, our preferences, and plan and treatment for an individual. But also keep in mind the overall regional aspect, the global aspect, the national aspects, and try to create an ambience of social awareness related to diabetes and obesity, so that we can offer the best of these newer molecules. But also at the same time, we ensure that people are more and more aware and they pick up the right choices, so that the need for these molecules actually go down. So thank you once again for joining today. I now hand it over back to Saurav. Thank you, Saurav, and thank you, everyone.
Thank you, sir. Very insightful information about, I think, the topic which everybody wants to know. We have Dr. Chong here, who is the chairman for CMAAO. We have Dr. Anil Kakri, who is the president of CMAAO. And we have everyone else from all part of the world. So let's start the question answers round. Dr.
Thank
Chong.
you, Saurabh, and thank you, Dr. Bhattacharya, for your wonderful talk. It's a good summary of what we've all been looking at recently. The GLP drugs, very, very impressive. I noticed that recently there was some talk about eye complications in the GLP drugs. Do you have any comments on that?
I think so. This is something which we really well. These are all. It's an evolving era of medicine. So there are two things we need to be careful about. So there are two groups of complication with this molecule. So one which was reported in the clinical trial was worsening of diabetic retinopathy, and that has been attributed to rapid control of glycemic control, mostly can even occur with insulin. And so it's mandatory that a person with diabetes, if they're planning a GLP-1 based therapy like semaglutide and also tirzepatide, should undergo a baseline retinal screening and should be starting it in a guarded way. And so it's not an absolute contraindication, and there are actually dedicated RCTs like Focus which are going to address these issues, and we'll have more answer once the trial results get published. So that is one area where you need to be careful about. The other area is NAION, so non-arteritic ischemic anti-ischemic optic neuropathy. So that is something which have come up in multiple reports, mostly single center reports of people coming up with it's like a sort of optic neuropathy which is there with these molecules. So again, when we are talking about any unusual side effects, say maybe diabetic gastroparesis or intestinal obstruction or NAION. So what we see in the social media is that the numbers, so many people have developed this complication. So what we first of all need to understand, so obesity is a condition, or diabetes is a condition, so it predisposes to side effects like say pancreatitis. It predisposes to side effect like gallstone disease. It predisposes to even side effects like NAION. So if you look into the numbers of NAION in diabetes and obesity population versus so it's like, say, 0.2 in the percentage is like 0.02% will have these conditions even without this molecule. So what the numbers right now show is that it's like the numbers go up to like 0.04. So the overall, the numbers are very less. Still, we need to be careful. So we do not have a RCT data where this has been proven. So this has come up, but again, like pancreatitis, like gallstone, NAION is a condition which is also more common in diabetes and obesity. So whether it's the molecule itself or is the predisposing condition which is leading to it, we still don't have an answer. So, but I think the bottom line remains that we need to be careful, we need to be watchful. And if somebody is having risk factors, so maybe again, a retina screening is not going to give an assurance, okay, you won't have NAION. So NAION, it's very difficult to pick up people. So there are concepts like cup disc ratio and optic cup depth. So those are being studied, but again, those are gray areas. So we really do not have a optimum screening test for identifying people at risk for NAION. So cup disc ratio may be one, but again, this is an area. Focus is looking at it. The semaglutide dedicated trial for eye complications, they're also looking at NAION. And I think we'll have some answer once the reports come up.
Thank you, Dr. Bhattacharya. I agree with you. I think the population we're treating, this obese diabetic population, is not a very healthy one to begin with. So again, I think the benefits outweigh the risks.
Right. Benefits are much more.
Yeah, the benefits outweigh the risks. So I suppose we just have to ask the patients to watch out for any abdominal pain or any vision problems as a matter of just. But we are seeing that the benefits do outweigh the risks. So quite an amazing class of drugs, I must say.
Yeah,
must say. Monica, do you have anything to say?
Yes. Thank you, Dr. Bhattacharya. That was a fantastic presentation. I think it's always relevant to the population that you're speaking to right now. My question is what is the availability of the GLP-1s right now where you are? And what do you anticipate as being the accessibility for your patients? Is it going to be affordable? Is it going to be available? And what do you think the uptake is going to be in the next 6 to 12 months in terms of the use of GLP-1s?
Thank you, Dr. Monica. Very, very important question. And so India was late to catch the bus. So it has been, semaglutide had been there in US for, I think, in 2017, 18. And then it later got approved for obesity as well. Tirzepatide has been there for last 3 years or 4 years in US. So India, it's oral semaglutide or Rybelsus was the one which first got launched around 3 years back. In 2025 early part, tirzepatide was launched, followed by uh, injectable semaglutide in the form of Wegovy and Ozempic. So these, as of now, they were all apprehensive how the take up is going to be, but tirzepatide is the highest selling molecule in India right now. So even though there will be a large section of the population who might not be able to afford it, but at least uh, we consider there are two major challenges in India, in Indian context, or in maybe in Asian context. One is the cost and one is the GI tolerability. So but there are people who, so a large section of the population can still afford it. The cost is still less than that of US, maybe 1/5 of the cost that is being that is there in US. But tirzepatide and semaglutide, both they are very much being used both for obesity as well as for diabetes. And in the next 4 or 5 months, semaglutide is going to come out of patent in India, because it has been 10 years or so. That is a recommended time when the patent can go off for Indian context. So will be having semaglutide being prepared indigenously, and the cost is even going to come down further. So I think that is going to definitely increase the accessibility, and we pay the receptivity as well as the clinical benefits. That is quite amazing. So we have been using it in hundreds of our patients are on it already. But still the cost is slightly on the higher side. In spite of that, there is a large section of the population on it. And once the cost comes down, there will be even larger section who will benefit from this molecule.
Okay, so I have two follow-up questions. One is one's a statement. I would love to see published data on the use of GLP-1s in a population that differs in how its fat distribution is and its risk profile.
Right.
We always talk about the thin fat model, right? So how does GLP-1 influence the overall diabetes, obesity control in this population, and how does it differ from the West? The second thing I would like to see is the outcomes of whether or not, if you're able to transition these patients who are now able to eat a smaller portion, able to maintain their weight, and are you able to wean them successfully off of these GLP-1s, or are they going to return back to their pre-GLP-1 state? And I know that's a big issue. Like the first question that everybody asks when they get put on a medication is like, yes, I love the induction phase. I'm getting, into that level of control. I feel great. It's reversing all my diseases. But is this a forever drug, or is this a temporary get them to a final state? So I would love to see how these medications work in our population and how it's different from the West. I mean, obviously we see every single person here on it, but they have a different profile for the reason they start. They have to have a BMI of 27. They have to have a comorbid condition. They have to have sleep apnea. They have to have asthma. They have to have something else that's going on. But, if you don't have a BMI of 27 here and you're Indian, you might still be a candidate for it, but I would love to see how it's applied in the Indian population or South Asian population.
So I think both are very, very valid questions. So first I will take your first question. So I think that requires a study, but if most of these trials had an like Indian numbers were there. So maybe not very high. If you look into STEP or some amount or of both tirzepatide and semaglutide, so there were Indian data, and both of them did subgroups of like body composition and some of the Indian body composition data. So I'm not aware that those are markedly different, but totally agreed that this is an area where we need to focus our research on, have a baseline body composition, and how the body composition is going to differ with this newer agents, which brings down the which is bringing down the fat primarily, but also has an effect on lean mass. So since it's a thin fat obesity, so whether that pattern differs or not, an important area of research which should, I think we should focus on this. And I think over the next 2-3 years, because this is only the first year which is where we have been having this molecule, but I'm sure we'll have more data as we keep on using it and keep on researching it. Related to the next question, so I think the $1 million question is, you have raised that how to what to do with GLP-1 when you have achieved, as we see again in uh, achieved a mark or achieved a goal, what the person who have been taking it considers is okay for him or her. But again, there are two ways of answering it. If you are a believer that obesity is a chronic relapsing disease and has to be treated like diabetes and dyslipidemia and hypertension, so you can continue at the maximum tolerated dose or the maximum dose, or at the minimum dose where the patient is able to maintain it. So related to the other part where actually the person wants to get off it, it's everything is being tried. You also know, I also know. So people have tried micro dosing, people have tried alternate week dosing. So we have trials coming up like tirzepatide followed by orforglipron. So whether a oral maintenance therapy will be able to do it. So I think there is a trial which is coming up with orlistat, whether though the mechanism is totally different, whether it will be able to do it or not. So I think this is a gray area. This is an evolving area where we don't have a evidence-based answer, because people are just entering those phases where they are planning to get off because okay, they started at a BMI of 32, now their BMI is 25, and most of the complications are settled and they are not very keen on spending so much. So individual choices have to be kept into consideration, and I think each and every case will be different, and we'll have to balance the uh, risks, benefits, morbidity profile, whether the person is having diabetes or not, other complications. If we give a trial of weight discontinuing, what is the rebound, whether the person is ready to go back on it, whether weight cycling has a challenge or not, is a challenge or not, that also we don't know. So that is something we have more and more papers related to weight cycling coming up, whether it's waxing and waning of the weight, does it have a long-term negative impact, do we lose more muscle loss? So these are all gray areas which you will also see, I will also see, and hopefully will have a definite answer over the next 5-10 years.
Thank you, Dr. Bhattacharya. There's a question in the Q&A in the chat group. It says, can Mounjaro and SGLT2 be combined in diabetes? I believe so. It can be. Can you answer
Yeah,
that?
definitely. There are trials also. So most of the semaglutide or tirzepatide trials which were done on the diabetes population, there were like 20-30% people who are already taking SGLT2 inhibitors. We have even semaglutide trial on heart failure where even a larger number of people are already on SGLT2 inhibitors. So that is not a if they are covering two different aspects, pathophysiologies of diabetes. So I don't think there is any problem with that. The benefits are only going to be still persist. Whether it's additive or not, it's not very sure. But or whether it's synergistic or not, it's not very sure. But whatever medication which can bring down complication, we need to consider for our patients with diabetes and related complications.
Thank you, Dr. Bhattacharya. in Singapore, I think semaglutide was registered in 2021. So we've experience of quite a couple of years now, and some of the patients have actually stopped semaglutide. But I find that basically for my own practice is that they have to change their lifestyle. If they continue with the same old lifestyle, good luck.
So it has to be incorporated. So it shows the average trial both with semaglutide and tirzepatide discontinuation, though it's a 50% weight loss, weight gain back, which is seen. So, but again, whether ensuring dietary compliance and reinforcing lifestyle changes, we can maintain that. So still there will be some amount of weight loss, whether it can be less with this. Again, there will be personal variation, and people do not follow lifestyle, so that is why we need all this. Having said that, that is the best form of therapy, but we know the limitations.
Yeah, and you're right, they all start doing all kinds of funny dosing regimens after they decide to stop the medicine. They are doing some sort of alternate day microdosing, god knows. They'll all go figure out themselves. But thank you very much. I think it's been a very helpful discussion today, and these drugs have been quite a revolution in terms of treating obesity, which has been a huge problem globally, and diabetes as well, linked to obesity. Our population here is 11% diabetic rate. So one in 5 at 30, and 1 in 3 at 60. So first world problems, I guess, and sometimes also not only first world problems. Thank you very much for your most kind presentation. And there's a question from Prof. Ashraf. Prof. Ashraf?
Thank you very much. It is an excellent talk indeed. Extremely grateful. My question is very simple, that if you find some complications, whether the treatment should be stopped or one can continue with the treatment and at the same time to address the complications of the treatment. Thank you.
So I think that's a very relevant question. So if you develop pancreatitis once on treatment, so you are not going to restart this treatment for sure. So that is an absolute contraindication. So if somebody develops a gallstone, if undergoes a cholecystectomy, and then after that the person wants to restart, that can be an option. NAION, if somebody has developed, again, you are not going to restart, because that is a permanent, irreversible condition. You can't follow it up. PDR, we let's wait for the trial to come out, and we'll have a better response. So it again depends on the type of complication. So some you can restart, maybe something like a gallstone. GI side effects, so it's sometimes it's not tolerable for some. So people, if they had a bad experience, though most of them will tell, I don't want to give a trial of restarting. So that varies from person to person and according to the situation. But pancreatitis, no. Gallstone maybe after the cholecystectomy, and for others we would need to decide on a person to person basis, and not for NAION if that is there.
Oh, Dr. Bhattacharya, thank you, Dr. Prof. Ashraf, for your question. Dr. Bhattacharya, there's a question on combination of Mounjaro and semaglutide.
So I don't think that will be a rational combination. So it's a Mounjaro is already a GLP-1 and GIP combination. So you are only going to increase the adverse effects. There are no trials, there is no evidence, and there is no logic. I don't think so. We might be looking at a triple agonist which might come up, but again that will be targeting a different pathway altogether. So if you are looking into GLP and GIP, adding another GLP, so even if you should not be combining DPP-4 inhibitor with a tirzepatide or semaglutide. So that is because both are incretin-based therapy, and the incretin effect of the GLP-1 analogs are so stronger, so you are not going to have a DPP-4 effect anyway. So that is something where if you are combining a DPP-4 even with a semaglutide or tirzepatide, that is most probably unnecessary. So you only no rationale for combining tirzepatide and semaglutide.
Thank you. That was from Angelique, and thanks, Angelique, for that question. And the last comment is from Dr. Ravindran. Most of the time, issue is when you lose weight, is combined effect of muscle and fat. But when you stop these medications, weight gain is basically mostly from fat, which is very bad. Well,
I think the weight cycling is we are, so there are actually some papers on it, but there are more papers coming up, and I guess so this is all evolving. So it's 5-6 years of use for US. It's first year of use for us. So how how much? So as Dr. Monica told, that we really need to have body composition data, at least for some section of our people who are using it, and then we try to analyze what is the muscle loss, what is the fat loss, whether there is a ethnic variation or not, and when they even stop it, how much, what component is coming back, whether how much is the muscle actually lost, say after discontinuation, what is the muscle. So these are all research areas which thank you for raising this question, which we need to look into. But I'm sure there is data coming up from US, and I'm sure that will data coming up from India and other parts of the world also.
Thank you very much. And such a fascinating topic, as you can see from all the questions that have been asked and all the comments. Thank you, Dr. Bhattacharya, for this wonderful presentation and very engaging topic. We hope to see you again soon for another discussion on this fascinating topic or any updates. Thank you very much.
Thank you so much. Thank you for the invitation.
Thank you.